Thank you everyone for joining us today. I am Marie Norton, Territory Manager at Laerdal, Australia, New Zealand. I am your moderator for today's webinar. During the session, please send your questions through the Q&A function. We will have 15 minutes at the end of the webinar to have them answered. All attendees will be muted to minimise background noise. This webinar will be recorded and you will receive an email with a link to the recording in the next 2 to 3 business days. Today, we are privileged to have with us Professor Simon Cooper, Associate Dean Research at the School of Health, Federation University, Australia. During this webinar, Simon will be sharing contemporary education approaches in the undergraduate education. So thank you, and I now welcome Simon Cooper.
Thank you, Marie, and welcome everybody, and thank you very much for having me here today, and thank you very much for attending, and also thank you for Laerdal for setting up this program of work. Okay, today I'm going to talk about contemporary approaches to education, simulation, technology and engagement. And I'm a professor at Federation University, Australia, which is Australia's newest university and was a merger of Ballarat University and Monash University a couple of years ago, or campuses of Monash University. And we're based predominantly in Victoria. Okay, plans for this talk today. I am going to institute a few brief pauses throughout for reflection, for you to think about some of the things I'm going to be talking about. I will ask you for your thoughts. Please help me by responding to questions, and if not, I might call you out by name, so watch out. Okay, to lead in. Objectives. The objectives of this presentation is to consider educational motivators and best practice in clinical education, and to illustrate a range of approaches that enable us to develop and evaluate clinical performance. My main focus will be on undergraduate nursing education, but I'll also use postgraduate examples throughout. Okay, this is the first pause, almost immediately. I want to give you just 3 minutes to think about how you motivate and inspire your students, and how you were inspired by a teacher. I'll come back to you in 3 minutes, but I just want to get your response to some of those questions. Okay, I'm guessing that we've probably had enough time to think about that first point. Any of you want to talk about an inspiring teacher that you've had, or how you particularly motivate your students? Don't forget to unmute if you're about to talk to us. Or Graham. Hi, Graham.
G'day, Simon. How you going?
Good.
The most inspiring academic who ever taught me was a fellow called Dr. Peter Rich. He retired from RMIT Bundoora only about 4 years ago, and I was an undergraduate student in the mid-1980s, so he was there for some time. He learnt the names of 100 first-year students from the photo board. So day one, year one, I walked into my first lecture for anatomy, sat up the back, started talking to my friend. He pointed at me, "Young Mr. Folds, can you be quiet, please?" And he knew every single name of every single student. I went back there 25 years later. He looked at me, reflected for a minute, "Folds, Graham Folds." And he could tell what I'd done from a career point of view. Absolutely inspiring. Absolutely inspiring.
Excellent. Good example, Graham. Or good example, especially if somebody with a photographic memory, I think. It's excellent. Made you feel involved anyway. Anybody else?
It's Ian Balducci here.
Hi, Ian.
That students are inspired by how enthusiastic you are about the content that you're delivering. One of the things that can be challenging, and I hear my teachers saying it all the time, is that, oh, I've got to go and deliver and it's so dry and terrible. And I think that for me, I was always inspired with people that could really just seem to be so excited about what they were delivering and could share that importance of that into their practice. So for me, I think that's that's one of the great ways. It's also too, I think, if I look back to the teachers that inspired me, I remember the people that were cheerful, that were approachable, that were genuinely excited about what they were actually delivering to the class, to the group, whether it was in a lab or it was a lecture. I think my worst experience was in the anatomy classes, and it was back in the days of overhead projectors and acetate, and every slide that went up was simply a acetate of words that were about a centimetre tall, and it was just words on a page, and the lecturer just talked, and there was nothing. Hated every session. So yeah, for me, I think it's really just sits around that genuineness of that excitement and the desire to teach.
Very much. Thank you for that. Anybody else want to add anything? That's good. I'll keep going. Thank you both very much for that input. Okay, so on to the main bit. So what should we be hoping to achieve in education? Key thing is a transition from training to education for higher level decision making, surface to deep thinking, independent decision makers, multi-professional links and interprofessional learning, clearly evidence-based practice, applicable focused curricula, and quality placements. If you're from a nursing background today, you'll know that, or you may know that the Commonwealth Government instituted a review of nursing education by Schwartz in last year in 2019. His suggestion was that a nursing degree in Australia, currently 3 years, should move to 4 years, and there should be improvements in simulation and simulation enhancement, and a range of other suggestions. I'll come back to some of those a bit later. Also, what are we hoping to achieve in education? There's a lot of talk about students being work ready. In my view, they never are. How can a student be work ready after a 3 or a 4 year degree or a 5-year medical degree? In essence, they're probably not, and it's probably something we can't achieve. But what we should be able to achieve is work safe students who are safe, who are considerate of patient safety and are able to work effectively in the workplace. But no way can a university or education provider ensure that everybody is work ready. We'll come back to some of these points, and you can challenge me on them later. Also, really important that we think about translational impact, the clinical impact of what we do as teachers and educators. And I've got some more details about that later. Very important that we measure not only students' views, but what difference does it make to their practice. It's harder and more expensive to do, but there are ways of doing it. Also important, especially with current challenges about clinical placement, to ensure that we have quality placements. The Council of Deans of Nursing and Midwifery have recently commissioned a project to enhance the quality of clinical placements across Australia. And from that, we produce something called a PET tool, or a placement evaluation tool, which will be used and has been used for students to rate their clinical placements. At the moment, that's been focused on nursing clinical placements, but that particular tool, easy to complete, very feasible, valid and reliable, should be used, or we think it can be used in any profession as a quick snapshot of placement quality. Many of you will be aware that there's been a lot of talk about simulation as an adjunct or as a replacement across the world. Formerly in the UK, nurses had to do, I think it was 1,200 hours, of which so many hours could be used as simulation. That's not the case now, but many countries are thinking about using simulation, certainly as an adjunct, but possibly as a replacement. And on the link between that bullet point, you'll see a paper related to that. Again, we can come back to that a bit later, and I'll perhaps get you to think about those issues in a minute. The other thing to think about is the number of placement hours that students spend in clinical environments during their training. In Australia, in my view, that is very low. It's only 800 hours for nurses, or 20 weeks. In New Zealand, it's more like 1,300 hours. In the UK, I think it's about 1,100 hours. In South Africa, it's slightly higher. So in general, across the world now, Australian nursing students are placed for less hours than anywhere else in the world. There's lots of issues related to that, and many of you will be aware of, including costs, including the availability of placements. But I think we do have to think about either enhancing the quality of placements and keeping the same hours, or perhaps increasing the hours. Okay, so just another brief pause for you to think about some of those thoughts. I'll probably just give you a couple of minutes so I don't run over time. So should students be placed for longer? Should simulation replace clinical practice? How should we improve clinical placements? And then should nursing degrees be over 4 years as opposed to 4? And what do you think about the length of nursing degrees for the other health professions? I'll come back to you in we'll say in a couple of minutes. Okie doke, I'm back to you guys. Anybody want to comment on any of those questions? Louise, Ben, David, Nicole?
Louise and Ian, I can see that you've posted in the chat. Would you like to each unmute and liaise with Simon direct? Only if you feel comfortable.
Sure, happy to. I think in relation to placement, of course, I think more placement is better than less. So for me, absolutely, but it needs to be appropriate placement and good quality placement. But securing it, of course, is the challenge. We all know the challenges we face with real life practice. In relation to simulation, at the moment, my experience of simulation is that it's not robust enough to be able to replace clinical practice hours, because I don't see it as being multidisciplinary. I don't see it as being extensive enough for scenarios to really reflect what happens in the real world. How do you get your doctor's rounds, for example, or your allied health professionals coming in. And so if I deliver an interdiploma of nursing, so don't have a Bachelor of Nursing facility that I've got access to. So we don't deliver allied health programs that we might be able to do some cross specialty area simulation. So that would be my view on that. And I don't know about the next two. I don't have answers for either of them. Should a degree be 4 years? Maybe. If it was 4 years, we could get more placement in.
That's true. Thank you for those excellent points.
Yeah, Simon, I could probably...
Hi, Ben.
Hi, how are you?
Good.
I could probably add a bit of a student perspective to this, I guess, because I've been a student nurse in the past. And I suppose the issue with longer placement hours in the current state that placements are in Australia is the economic impact on the student. Because, myself, I'm 30 years of age, and I've got a family, and it just became non-viable to continue with studies, moving from enrolled nursing to registered nursing because of the length of hours. There's a hell of a lot of hours there that have to be unpaid as it stands, and I think possibly that limits the people who can actually do the degree, especially when we're talking about enrolled nurses who maybe want to upgrade their qualification or move to a different qualification. So that would sort of be my concern about a longer amount of hours, although I guess many would agree that there does need to be far more on the job time. Does that need to happen in a different way? I mean, I know other health professions such as occupational therapists and the like, they have a very different way of doing placement. in that, you know, they can be sort of once a week or at different time junctures. So I wonder if maybe it's that rigidity around placements in Australia that is limiting us rather than just pure number of hours.
Thanks, Ben. Thank you both so far. Any other quick comments on that? Comments on those slides?
Yeah, I'd be happy for nursing to be a 4-year degree if that fourth year was an internship year that was paid.
Yes, David, good point. And I think there has been some discussion about that. So yeah, great point. Okay, thanks all. Bearing in mind time, I'll just keep going. Okay, so what focus and approaches to healthcare education are required or could be considered? Okay, in my view, as in assessment, multiple methods of teaching are the best methods of teaching, just as multiple methods of assessment are the best methods of assessment. So think about all the different ways that you could and perhaps should teach. Interprofessional episodes, I think, are important. The key word there is episodes. I think professions should be taught together to mirror where they work together in the real clinical environment. So examples of that would be around resuscitation training. Really important to have rigorous clinical assessment. For example, passing a simulation, or pass the patient, pass on from the patient. We should ensure that students are adequately prepared and adequately assessed through rigorous methods. And I'll come back to some of that, I'll probably mention OSCEs a bit later. Introduction of entry and re-registration requirements. Schwartz, in his review last year, suggested that we do need a USA equivalent NCLEX examination. Whether that will happen, I'm not sure, but many professions do have a final examination prior to reaching registration. And we should probably think about having something like a patient safety driving test, a rigorous assessment to ensure that students are ready for practice, all of which demand a change in education approach. I'm going to work through a few different ideas just to get us thinking about some of these issues. Clearly, currently, and as we are today, web-based resources and self-directed learning are really important. Many of you will have digitalized curricula. Many of you will have lectures online. My own university has actually stopped doing face-to-face lectures. They do tutorials and labs. Many of you will be aware of massive open online courses, or MOOCs, which are available free of charge from the major providers. At the moment, there's a dementia course and a TB course that I've noticed in the health disciplines. Laerdal, of course, has produced the fantastic virtual simulation program, which you can access through Laerdal. There's a range of Second Life software options around virtual hospitals, and I've listed there the top 10 sites. In my own work, I produced something called the First to Act web program, which is a program designed to enhance the management of deteriorating patients by primary or first responders. What should we do? What do we do in the first 8 minutes of a patient who acutely deteriorates? In this particular software, we have a range of resources from pre and post multiple choice questionnaires, voiceover presentations, a course handbook, and at the moment 7 interactive scenarios with real patients or simulated patients, where we filmed patient actors that were deteriorating, included a range of interactive clinical tasks that appear as pop-up videos, e.g. taking a BP and ECG, include performance scores and a certificate to participation on completion, with a full education management system available to users, universities and hospital departments, education departments. The outcomes of that software have been good. A range of performance and evaluation data that demonstrate positive outcomes from this form of learning, this tool of learning. around 30 plus peer-reviewed publications relating to it. To date, we've had 20,000 completions for this 1.5 hour program. It's available on HTML5 with 5 adult and 2 obstetric scenarios. The HTML5 means that it can be used on your phone and other sources of access. So those sort of programs are good. As somebody mentioned earlier, I don't think they're necessarily a replacement for face-to-face learning. I think they're an adjunct to maybe face-to-face simulation. They're just part of our resource kit for learning and teaching. We'll just have a brief pause here because I'm going to get slightly worried about time. So I'll just give you 1 minute. What are the advantages and disadvantages of web-based educational approaches? How do you see this developing over the next 5 years? I'll come back to you in a minute. Thank you. Okay, any thoughts on that one? Anybody want to comment on where you see us in 5 years' time, especially after this year, perhaps?
Hi, Simon, it's Nicole.
Hi, Nicole.
Sorry, I've been off. I haven't unmuted because my bulldog was absolutely snoring the house down. Now she's a little bit quiet, so I can duck in and then duck back out again. I was just thinking along the lines of, haven't sort of thought about the 5 years' time yet, but I think, you know, the issue with a web-based educational sort of model is that, you know, nursing is an interpersonal, you know, profession, and you know, I've done lots of distance learning myself, and I know there's no real sort of person-to-person interaction or contact. It's very much an individual thing, and, you know, you have to be self-motivated to complete it yourself. Some courses have been interactive. I did the flexible learning and simulation course through UTAS years ago. And that was, you know, that was quite an interactive course with other students, but generally, you know, you're very sort of much on your own. And I think most of our student feedback, even, you know, just in this COVID times, a lot, you know, there's quite a few that aren't coping with the online method and much prefer their face-to-face, even, you know, with lectures, etc. Of course, you know, I think all of us are still running clinical labs, and they're really cherishing that time to come in and you know, be part of the team and you know, do that hands-on skills, etc.
Thanks, Nicole. Great points there. So maybe a blended learning approach is what we're talking about, really, aren't we?
Yeah, I think so. I think you know, there is scope for blended. I think definitely, but I think, you know, I mean, I don't think ANMAC or ASPA will let us, you know, go online completely anyway. So
yeah, exactly. Any other quick comments?
Ian Balducci, just to read out the chats, he's also mentioned advantages to the digital is that they are flexible in the delivery and can be viewed anytime, anywhere, as many times as students choose. And disadvantages is that it's static scenario and there is no opportunity to ask questions or clarify. However, huge market in the future has been pushed along by COVID, which I think we can all see. Ian, by all means, if you'd like to add to that directly with Simon, please feel free.
No, that pretty much sums it up. I think, yeah, there's great opportunity. I've seen some newer resources and things that are a little bit more interactive and 3D, and you can click on suction and, you know, you move through a scenario and you've got to click on the correct pieces of equipment to pick up. And so I think there's lots of things happening. I reckon it probably needs, though, to be developed beyond something online and pushed into an Xbox or a PlayStation or some other platform that makes it truly interactive, but who knows.
Thanks, Ian, very much. Thanks, Marie, for reading the chat out. I think for me, it's the repeatability, which Ian mentioned already. You can just repeat the sim, so all of which is useful. Okay, I'm going to keep us rolling. Okay, so we've talked about some of the online approaches. What are the alternative artistic approaches to education that we could also consider? You may be aware that there's been a number of art for health projects across the world. Many anatomists use life drawing, anatomy and art projects. There's projects around storytelling, around palliative care in order to engender empathy, etc. It was a good study a few years ago in Melbourne using art for visual foci, perspective, culture, death and dying, where students were taken to an art gallery. And I'm guessing that many of the audience will have seen Mask Ed, developed by Kerry Reid Searle in Queensland. If you're not familiar, if you look at the inset picture on the bottom left-hand side of the screen, that's a lecturer with a very realistic mask that she dons, and she becomes the patient. The idea is that she simulates perhaps a elderly lady with chronic disease and diabetes. The students around her, as you can see in the main picture, take a history, do what they need to do to her, and then the lecturer demasks and debriefs the student. Very high fidelity, because once the lecturer is masked, she is very believable. And there's been some good outcomes from that work, good alternative way to teach as an addendum to other approaches. Other games and activities that you could consider. There's a DVD here called Games, Games and Games. There's a game called Abdominal Twister, where using the Twister game, you replace the different spots for points of the abdomen. There's a game called Survivor Reviver around O2 sats. There's another game about Name That Arrhythmia. There's a game called ECG, the ECG game, where you get 5 students to leave the room and they walk back in as a PQRST wave, and obviously differing the speed in which they enter the room to simulate an arrhythmia of some sort. That's a great one to play, and it's good fun. And there's other games around leadership and fellowship with blindfolds, etc. Just as an example of the leadership one, this is an example we used for the leadership game, and we asked participants to draw an emergency department leader to begin to think about what the key attributes are for that individual. And you can see with this illustration, they thought an ED leader was able to wear several hats, was a good listener, they were hands-on, they were grounded, they were thick-skinned, of course, and broad-shouldered, and dynamic and aware. Because of time, I won't get you to reflect on that, but we'll probably may consider that at the end of the talk about what methods you may use in addition to perhaps some of the ones I've mentioned. Okay, last few slides, clinical skills development and assessment. Again, many of you work probably a lot in simulation. So don't forget the importance of fidelity and psychological fidelity or believability. I've got 3 examples on the screen in front of us. Top left-hand side would be an older Laerdal ALS mannequin, very useful in the resuscitation type scenarios, very advanced technology now that can make this sort of scenario very believable. And use of technology is very beneficial in that kind of situation. On the right-hand side, you may or may not have seen this, but this patient actress is wearing a birthing suit, the silicone suit that you can see over her groin. She's able, below the bed is a large bottle full of blood, and at an appropriate time, if you were simulating a PPH, she's able to pump several litres of blood out of her vagina, which is obviously highly believable and high fidelity when you're being challenged by how to manage a PPH in that kind of situation. The slightly darker picture at the bottom is just an illustration of the use of a patient actor. We like using patient actors. In my field, the downside is you can't simulate a drop in blood pressure because the patient can't drop their blood pressure. So you do have to intervene as a lecturer and say the blood pressure is So that's perhaps one of the downsides for that. Don't forget non-technical skills. So non-technical skills are defined as leadership, teamwork, situation awareness, and decision making. So whatever you teach, whatever you're involved with simulation, don't forget those elements because they're obviously core to patient safety. Interprofessional episodes have been used in, for example, the Dementia Project, which is a big project run by Monash University for the enhancement of the management of patients with dementia. Great simulation program run across the state, I think maybe nationally now. It's clearly important, and I mentioned earlier, to think about interprofessional episodes for, in the acute events, MET teams, resuscitation teams, because that's when individuals from other professions have to work together cleanly and in handover, as is the case in handover itself. So handover training should be with other professions. Other things that people have started to measure is situation awareness, which originally comes from the aircraft industry, cockpit views of situation awareness. And in medical spheres, people are becoming much more aware of the need to understand and perform situation awareness appropriately. There's a good technique of measuring that called SAGAT, which stands for Situation Awareness Global Assessment Technique, where you can measure in simulation how aware people are of their situation. Other things to think about is rigorous tools that measure performance. My example in team is an emergency one again, which is the team emergency assessment measure, which is a straightforward tool which is used to measure the performance of resuscitation teams, pediatric trauma MET teams, obstetric emergency teams. It's been used in which is very useful not only for research purposes about how your team is performing, but in order to enable rigorous feedback to teams about how they've performed. Another good technique around decision making, this is slightly more technological, is eye tracking. There's some really good software that measures how people perform by tracking their eye movements. I'll give you some photos of that now. There's two ways that you can measure decision making through eye tracking. One is this, one example is these Tobii eye tracking glasses that you see in front of you. The glasses measure, record, and download where you have been looking. And you can also have screen-based eye trackers that would measure, for example, where I'm looking now and how my eyes are moving across the screen. Very useful way for understanding and measuring what people are thinking of at any particular point. I'll explain that in a bit more detail on the next slide. So here's an example of a screen-based eye tracker. So the person is looking at the ECG. The bigger the red dot means the longer they have spent on that point of time. Then they are moving to what they're actually doing or record this time they're spending looking at and taking the blood pressure. And you can see they're moving between those 2 points. I think there's another slide here as well. But it will illustrate the track of people's eyesight and therefore thought patterns between various criteria. So this is a first to act scenario. And you can see that first of all, they've decided to consult the patient. They've listened to what the patient's been saying. They've been looking at the patient, and they've moved from various other points and triggers. For example, they've changed the bed position, which is the bottom left-hand side, and they spent time looking at that particular prompt. If you do this sort of thing with students or qualified staff, the best way to understand decision making is to record output from this kind of software, play it back to them, and then get them to consider and talk about what they were thinking at any particular point of time. That will allow you to track their thought patterns and perhaps change behavior at a later date. This is probably the last but one slide. Okay, clinical impact. I mentioned this at the start. So it's really important, whatever we do in our teaching and learning, to consider not only the impact on students, which you may be doing through Kirkpatrick's hierarchy. What's their thoughts about the program is level 1. Level 2 is what have they learnt? You may be doing tests pre and post. But most importantly, level 3 and level 4 on Kirkpatrick's hierarchy about, does this program of education make a difference to their practice? There is not much evidence around that demonstrates that we're recording this work. I've got 2 examples in front of us on the screen. In a systematic review of patient deterioration programs, we identified 23 papers where education impact had been measured, but only 3 of those identified clinical impact. A really good classic paper related to that is Croft's, back from 2007, where he did only 40 minutes of simulation training, and it significantly improved the management of shoulder dystocia in practice. So it doesn't necessarily mean we need to spend a lot of time in simulation, but we do need to think about whether or not it makes a difference to practice. And secondly, the last bullet point down there, another Department of Health Victoria patient deterioration simulation study studied 2 training interventions, web-based and face-to-face, at 4 hospitals across Victoria. And in that case, we measured the clinical impact through MET activations pre-post intervention, healthcare practice pre-post intervention, and we did chart reviews before and after either the web-based or face-to-face versions. And we also did cost-benefit analysis, comparing either the web-based version or the face-to-face simulation version of our patient deterioration programs. As a very brief summary, I'll just say that there actually is no significant difference in outcomes between web-based and face-to-face simulation in that particular study. Okay, in summary, from the little chat we've had today, contemporary education requirements demand changes. Workforce demands being work-face or ensuring our students are work safe, and education changes a need for online learning, whether that's blended. It's probably not in isolation, but probably web-based and face-to-face. Delivery, consider varying and blending your teaching approaches, web-based alternatives, perhaps interactive artistic options. Make sure your simulation is contemporary and believable, and think about empathetic, inspirational teaching, which is what we started on. What do you remember about your teacher and how can you mirror that in your own practice? And just finally, evaluate the education and the clinical impact of your work. And over to any questions, and at that point I'll stop sharing my screen as well.
Thank you, Simon. That's been great. A question is great, like that you've brought in the artistic elements of learning, such a wonderful part of the student experience. You've also mentioned evaluation, and I just wondered, what are the challenges and successes and that you found in evaluating in measurable terms how students benefit from those artistic elements?
Oh, really good question, Marie. There is some evidence about gaming in healthcare and the benefits of that. I don't think gaming in healthcare has possibly been managed in the clinical situation. What's the clinical impact? From memory, the evidence is that gaming is very beneficial to students because it engages them so well and they do learn more. There is some evidence that mask ed has an impact. It definitely has an impact on engagement. It definitely has an impact on learning from memory. But again, I don't think those things have been measured in clinical settings. Does that answer your question?
Yeah, absolutely. Thank you. Another question that we have is, you started the session speaking about what's inspired everybody. And the question is, what's actually inspired you and how's that shaped your teaching?
Well, my inspiratory inspiratory, I don't think that's a word, but anyway, the person who inspired me the most was actually my, when I was back in the UK, we used to do a 6-month intensive care course, which was the hardest course I ever did. Much harder than my PhD, much harder than anything I've done since. And the teacher herself was massively enthusiastic about her subject, and she was an outstanding expert in AMP. And I learned more in AMP from her than I have done ever since. But it's something about her passion and her enthusiasm that made a difference to me. Also, over the years, to continue to answer your question in a slightly different way, what's made a difference in my teaching is looking at outcomes. So I spent about 10 years as a resuscitation officer doing nothing but resuscitation in the UK. We did improve outcomes, but what I felt was about 10 years ago when I moved to Australia was the big gap is around the need to stop patients arresting in the first place. And therefore, for the last 10 or 12 years, my focus has been around the management of patients who are deteriorating. And I think that's changed my focus of teaching, because that's what's needed and what's essential at that time. Both resuscitation training and patient deterioration management are obviously essential. But I think it's a combination of things around being inspired and being taught the right thing at the right time. I may have garbled a bit of that response, but that's roughly what I mean, I think.
Oh, excellent. Thank you. You took us on a journey with you, which was great. Nicole has also posted that gaming can have an impact, and that her children knew their way around Italy, one of my favourite countries, from playing Assassin's Creed, which I gather is a video game. They knew the history and never got lost because they recognised the layout of the towns. That's amazing.
Well, actually, that's a really interesting one, actually, because in essence, that's clinical impact. So it's made a difference to what they do in Italy, hasn't it? So they found their way around. So if you're looking at simulated hospitals, they will be able to find their way around in practice. So yeah, great example. Thanks, Nicole.
Yeah, thank you, Nicole. We have time for one more question. Would anyone like to unmute and ask a question? We're keeping it fairly informal.
Hi, Simon. It's Graham here again.
Graham.
I was really interested in your comments at the beginning of the talk about an NCLEX type exam. So many years ago, we would have a State Board of Nursing exam when it was a hospital-based program. And I know this is a contentious topic. What are your thoughts on that?
The lead-in for me, Graham, for that, it was mentioned in the Schwartz report, as many of you will be aware. To be quite honest, it's one of those things that I don't have a strong opinion of. I think there's definitely a need to have some form of entry standard. And I think NCLEX isn't necessarily the right way to go. What I'd much prefer to see is a clinical standard, a clinical examination, what I call a patient safety driving test. So a formal test and assessment, whether it be OSCE, whatever, in order to allow you to assess overall somebody's competence before they enter the profession. The problem with that is the logistics of it. That would be very hard to achieve. So probably what I'm going to do is sit on the fence and say, I think perhaps a combination of some form of final entry level qualification and a clinical skills test is applicable. And I think it's really necessary for re-registration in some way. And you may be aware, for example, for international students applying to the register in Australia, they now have to do an OSCE assessment in nursing. So some combination of those, I think, is important to ensure patient safety, if nothing else.
Thank you.
Question, Graham.
Perfectly. Thank you.
Fabulous. Thank you, Simon. Again, we thank both Simon and all attendees for your engagement today. We will send out an email with a link to access the recording in the next 2 to 3 business days. The next Sun webinar will be on the 22nd of October, where Marcus Rawle, Jennifer Keast and Christian Karcher will present on why well-trained instructors are the most important aspect of simulations, and experience with online instructor courses. Please visit our Laerdal website for further information on our Sun webinars, so both previously and those to come. Wishing you all a great day. Thank you, Simon, and we look forward to your questions at our next webinar.